Are pain management programs really the best thing for chronic pain patients? Do pain management programs actually work? Certainly the evidence seems to be very mixed there. In today's video, I'm going to be looking at this whole philosophy of why pain management programs do not seem to be working. And I'm going to offer you a possible reason as to why this is. And I call this actually the Sisyphean problem. And I'm going to suggest why breaking that Sisyphean logic is so important to really make pain management programs and any other treatment techniques more effective for our patients. So what do I mean by this really? We know that from evidence, when we give pain management programs, and these have been initially for those of you who are new to this, pain management programs in the UK are really considered to be a very good treatment offered on the NHS for long-term management of chronic pain. What it involves is usually a trained physiotherapist or a psychologist or an occupational therapist doing anywhere between a 6 to 8 week outpatient program of once a week or twice a week, a total of 20 hours of time given for a group of 6 to 8 patients, and that is going to bring about an understanding and skills acquisition to manage your pain and to accept your pain and to live with your pain. That's the underlying philosophy of the pain management program. But I would say that it is coming at the back end of a very long journey, which potentially is quite problematic for the patient, for us as providers and healthcare professionals, and then for our colleagues who are going to be delivering the pain management program, and ultimately again for the patient who has got to listen to what's being delivered in the program. And this is where I come to the second part, what I call as the Sisyphean logic or the problem in this issue. Now, Sisyphus is a Greek king who was cursed at that time to push a boulder up the hill, constantly being monitored by Persephone. And every time the boulder went to the top of the hill, it would roll down again. And so he was doomed to eternity to keep going down the hill, pushing up the boulder, and then it falls down and he has to start over again. And this particular model, I think, is very problematic, but it's also very prevalent in many aspects of healthcare, and especially in pain medicine, which I work in, I find that to be very, very common. Why? Because when patients come in, we get stuck in this particular logic of saying it's probably the structure. We do a scan, we say it's probably that structure, so that we justify, and maybe our surgical colleagues justify, that because it's the structure, we should do an injection or we should do a further surgery. And if that doesn't work, we go back and do another scan and we find another structure and we say it's a structure, so we go back. So we are almost rolling up the boulder up the hill saying we'll do this treatment and it should work, and then when it doesn't work, the boulder's fallen down the hill, we go back, start another scan and do the process all over again. By the time a patient comes to see me in the pain clinic, often they have seen a few specialists, few healthcare professionals, all of whom have thought that this is probably a structure. They've taken the boulder up the hill of doing some treatment, it hasn't worked, and then they start again. The challenge with this problem, as you can see, is that if you think that it's only the structure, the failure rate is likely to be very high when you look at the present evidence. But the patient and the healthcare professional have joined in this process of rolling the boulder up the hill only for it to fall down again. And then we tell them, and that's what the surgeons do, that's what we in the pain clinic do, we say, oh, there's nothing more we can do for your pain, you need to go to a pain management program. And that is a real problem, because by this time there's a very real chance that patients have gone on to what we call learned helplessness. They almost start to believe that nothing's going to work for them, so the chances of the next treatment making a difference are very less. And then when they hear that in a pain management program they've got to accept it and that's all it is, they don't see the value of neuroplasticity. It's very difficult to move away from the helplessness and the Sisyphean problem to actually say, now I can recover, I can change, I can become better, I can retrain my nervous system and become pain-free. That's a very challenging place for most patients, which is why the success rate of our pain management programs or any such group-based strategies are so less when you deliver it at the end of a Sisyphean problem. So how do you break the Sisyphean problem? I think that's where the opportunity of all healthcare professionals to get the right kind of pain science education to the right person, the patient, much earlier in the process. Not 5-6 years down the line, but it's got to be done potentially in primary care, maybe even as a public health, maybe as group-based campaigns. I would really love to hear in the comments what you think you should be doing. This is what I'm doing right now, moving into primary care to work with my colleagues to see if we can deliver this care upstream, to deliver this knowledge upstream, to prevent this whole issue of the boulder being raised up. I think the time has come for us to not recreate the parable of Sisyphus in our healthcare system. We can do better, and that's the opportunity I see. Thank you for watching this video, and I'll see you in the next. Thank you for watching the videos. I hope you're getting value from them. Don't forget to subscribe and hit the bell button for notifications on when the next videos are to be released.